You've marked it on your calendar. I mean, 84 days.
Yeah.
It has been exactly 12 weeks since you, or maybe someone you're trying to help, sat in a clinical chair for the highly publicized O shot.
Right. 12 weeks is the magic number.
Exactly. You went through the whole ordeal.
Yeah.
The blood draw, the hum of the centrifuge, the numbing cream, just the sheer physical vulnerability of the injections.
That's a lot.
It is. And the goal was to treat female sexual arousal disorder. And you were told to just, wait for the regenerative magic to happen. But here we are at the 12-week mark, and you feel absolutely nothing. Like zero change in arousal, zero change in sensation.
Yeah, and sitting in that position is deeply frustrating.
Oh, I can imagine.
I mean, you invest your time, your money, your hope into this regenerative breakthrough, only to be left staring at the ceiling, wondering if your biology is just, well, fundamentally broken. It's a very, very isolating place for a patient to be.
Which really brings us to our mission for today's deep dive. We are taking a stack of clinical trials, systematic reviews, and actual clinic protocols. We're talking guidelines from the Cellular Medicine Association and regenerative clinics all across the country to troubleshoot this exact medical mystery.
That's just so needed right now.
Right. We're unpacking the science of the non-responder. And to do that, we kind of have to start with the timeline itself, because 12 weeks isn't just some random check-in date pulled out of a hat, is it?
No, not at all. The timeline is firmly grounded in cellular biology. If you look at the source data surrounding platelet-rich plasma, or PRP, initial vascular and tissue changes, they should start registering within, 3 to 6 weeks.
Okay, 3 to 6 weeks for the start.
Right. But 3 to 4 months, so that 12 to 16-week window, that is when the peak results manifest.
Because you're basically waiting on a literal construction project inside the body. Like, the PRP is supposed to trigger neoangiogenesis, which is the formation of entirely new blood vessels, along with, synthesizing fresh collagen. And that simply takes time to mature.
It does. And by that 84-day mark, the cascade of biological events that were triggered by that initial injection, they've largely run their course.
Right.
So if you're sitting there with zero changes in sensation or arousal today, the window for that initial physiological response is closed. In the clinical literature, this officially classifies you as a non-responder.
A non-responder.
Okay.
Okay. So when a patient hits that wall, the investigation really has to branch in one of two directions, right?
Yep.
We either have to interrogate the patient's underlying biology, or we have to interrogate the syringe itself.
Let's start with the biology.
Yeah, let's do that. Because my reading of these clinical protocols suggests that a total non-response is rarely a failure of the PRP itself, but actually a failure of the environment it was injected into.
Oh, absolutely. The environment is everything. We see this constantly in the data, particularly with severe hormonal deficiencies. There's this fundamental misunderstanding of what PRP actually is. Well, it's marketed to the public as this, miracle tissue-building serum. But PRP doesn't actually contain the building blocks of tissue.
Wait, really?
Right. It contains growth factors.
Okay, things like vascular endothelial growth factor, or VEGF, and platelet-derived growth factor.
Exactly. Let's break down VEGF for a second, because endothelial refers to the delicate inner lining of your blood vessels.
Okay.
So when platelets release VEGF, it acts as a highly specific chemical messenger. It's essentially, it's like a foreman on a construction site blowing a whistle, signaling the endothelial cells to multiply and build new vascular pathways.
Okay, let's unpack this. I think I see where the biological bottleneck happens then. Is getting an O shot while severely estrogen depleted, basically like planting incredibly expensive high-tech seeds into completely barren, dry soil.
That analogy perfectly captures the dynamic, yes. In this scenario, estrogen is the moisture and the nutrients in the soil. Estrogen provides the structural bricks and mortar for vaginal and clitoral tissue. It's responsible for maintaining tissue thickness, elasticity, and just, baseline vascularity.
So without optimal estrogen, those tissues are starved.
Completely starved. The growth factors from the PRP can yell at the cells all they want, but the cells literally lack the resources to execute the work.
Which explains why this treatment can be so notoriously unpredictable for perimenopausal and postmenopausal women.
Right.
Because they happen to be the primary demographics seeking it out, but their estrogen levels are naturally depleted. If they aren't on systemic or local hormone replacement, the O shot doesn't stand a chance.
The tissues simply cannot respond to the stimulus. And, it's not just estrogen either.
What else?
The clinical literature points to several other biological saboteurs that act like a weed killer on this regenerative process. Chronic stress is a massive one.
Oh, because of cortisol.
Yeah.
Cortisol completely overrides the reproductive system, doesn't it?
Yes, exactly.
Like, if your body is flooded with stress hormones, it thinks you are running from a predator. So it actively shunts blood flow away from the pelvic region and toward your major muscle groups. You're basically locked in survival mode.
Right, which makes regenerative healing nearly impossible. You couple that with nutritional deficiencies, like lacking the core amino acids, vitamins, and minerals required to physically synthesize collagen, and the body's repair mechanisms are entirely stalled.
Regardless of how much PRP you introduce.
Exactly.
Wow. And I want to factor in the daily background noise of a patient's biology, too, because we often forget that everyday medications can actively suppress the arousal system.
Oh, everyday meds are huge culprits.
Yeah. Antidepressants, specifically SSRIs, are famously documented in these sources for blunting the neurological signaling required for sexual arousal. But the one that really caught my eye in the research was antihistamines.
Oh, antihistamines are a fascinating biological roadblock.
Right.
I mean, think about it. They're designed to block histamine receptors to dry up mucosal tissue in your sinuses when you have allergies.
Yeah, to stop a runny nose.
Right. The problem is that histamine plays a crucial role in local vasodilation and fluid secretion throughout the entire body, including the pelvic floor.
Oh, wow.
So when you block those receptors systemically, you are actively drying out and restricting blood flow to the vaginal mucosa.
You're counteracting the exact mechanism the OSHA is trying to promote.
Exactly.
And blood pressure medications function similarly, right?
Hmm.
By artificially altering how blood vessels constrict and dilate, which can restrict the very engorgement the treatment is meant to enhance.
Yeah, it's all connected.
So if a patient is a 12-week non-responder, marching back to the clinic for another shot is like the completely wrong move. The first step of troubleshooting is demanding a comprehensive blood panel. You have to audit the hormones, the thyroid, the nutrients, and the medicine cabinet to fix the soil first.
Optimizing the baseline biology is absolutely non-negotiable.
Okay, but let's assume a patient does all of that, though.
Right.
Her estrogen is perfectly optimized, her cortisol is managed, she's not taking any interfering medications, the biological soil is pristine, but the shot still failed.
Okay, yeah.
I mean, I've always viewed PRP as a highly standardized procedure. You extract blood, you spin it, you separate it, you inject it. It seems pretty foolproof. How does the clinical data explain a failure when the patient's biology is optimal?
Well, the assumption that all PRP is created equal is perhaps the biggest misconception in regenerative medicine right now.
Wait, really? I thought it was all the same.
Not at all. It is not just a matter of putting blood in and getting PRP out.
Yeah.
The physics of the processing and the biochemical activation vary wildly depending on the equipment and the provider.
So it comes down to the centrifuge.
It does. A centrifuge uses gravitational force to separate the components of your blood based on density.
Right.
The heavy red blood cells sink to the bottom, the clear plasma rises to the top, and suspended right there in the middle is the buffy coat, and that's what contains the concentrated platelets. Extracting that specific microscopic layer requires precision equipment.
Right, because the trial's investigating stress urinary incontinence, which I notice frequently overlaps with these sexual dysfunction treatments. They specifically utilize something called a region kit.
Mm.
And the literature notes this specialized system is calibrated to produce a 1.6 times platelet concentration.
Yes. And if a provider is, say, cutting costs by using a standard low-speed centrifuge or just a generic test tube instead of a specialized kit, they might completely fail to isolate that buffy coat effectively.
So what happens then?
You end up with a syringe full of plasma that has an incredibly low platelet count. You are essentially injecting watered-down instructions.
Oh, wow. But even if the concentration is perfect, there's a chemical hurdle too. Because I was reading about the activation phase, the platelets don't just naturally release their growth factors the second they're injected, do they?
No, they don't. They require a chemical trigger. In standard clinic protocols, providers must add calcium chloride to the syringe right before the injection.
Calcium chloride, okay.
Yes. This specific chemical reaction forces the platelets to undergo degranulation.
Degranulation, I love that word. Makes it sound like a microscopic explosion.
It kind of is. It's essentially a bursting open of the cell to release the VEGF and other growth factors into the surrounding tissue. If a provider skips the calcium chloride step or, bungles the timing, the platelets remain intact.
So they just sit there.
Right. The growth factors stay locked inside their cellular vault, and the injection will be biologically inert.
You know what it reminds me of? A glow stick.
Ah, that's good.
Like, you can have all the right chemicals suspended in the tube, but until you physically snap it and force that chemical reaction,
Yeah.
you aren't going to get any light.
That is a brilliant way to visualize it, exactly like a glow stick. And, beyond the chemistry, we also have to look at the geography of the injection itself.
The anatomy.
Right. The female pelvic anatomy is profoundly complex, and the clinical trials highlight a massive discrepancy based entirely on where the needle goes.
Yeah, there was a study in our stack where researchers injected PRP into the mid-urethra, primarily trying to treat incontinence. And the data showed absolutely no significant improvement in the patient's overall sexual function scores.
Which makes anatomical sense, right? Because the urethra is not the primary center for sexual arousal.
Obviously.
But contrast that mid-urethra data with trials that specifically targeted sexual dysfunction, like Dr. Runel's pilot trial or the Suggen trial involving 52 women.
The Suggen trial, yeah.
The Suggen trial recorded up to a 72% increase in sexual function scores.
72%.
Right. And the difference wasn't just the PRP, it was the precise anatomical target. They injected the clitoris and the anterior vaginal wall, commonly referred to as the O-spot.
But wait, the O-spot isn't just a singular button, though. I mean, it's a dense neighborhood of structures.
Oh, it is a highly intricate complex. It includes the Skene's glands, which are essentially the female homologue to the prostate gland, responsible for fluid production and internal engorgement.
Okay.
It also encompasses the deep clitoral neurovascular bundle. These are the physical structures that activate the entire orgasm system.
So a provider's technique is literally paramount here. Because if their needle is off by just a few millimeters, they might successfully regenerate tissue, but it will be the entirely wrong tissue.
Exactly.
You might walk away with a healthier vaginal wall, but you'll experience zero change in actual sexual arousal or clitoral sensitivity.
The precision of the delivery mechanism is just as critical as the quality of the serum itself.
Okay, so we have a clear diagnostic picture now. A 12-week non-responder is either dealing with barren hormonal soil, a chemically inert or watered-down PRP serum, or just a geographical miss by the provider.
Right?
Knowing all of that, how does a patient actually salvage the treatment? Like, if I'm looking at the clinical guidelines from these regenerative practices, what is the step-by-step playbook?
Well, step 1 requires patience. You halt any further injection treatments and you initiate systemic hormone optimization.
Fix the soil.
Fix the soil. And depending on the severity of the depletion, it takes an average of 2 to 3 months for hormone replacement therapy to stabilize in the bloodstream and begin altering the physical quality of the pelvic tissue.
Right, you have to let the soil absorb the nutrients before you plant the seeds again. So once that 3-month optimization window passes, the protocols universally recommend administering a second O-shot.
Assuming the provider is using a high-yield kit and targeting the exact anatomical structures, yes.
Okay, but I was trying to wrap my head around the logic of that. If the first shot completely failed to produce arousal, why would doing the exact same thing a second time yield a different result?
Because clinics frequently observe a phenomenon known as the cumulative effect. A patient who experienced a complete non-response to their first injection often reports dramatic, sudden improvements after their second or third. Because the first shot rarely does absolutely nothing on a microscopic level. Even if it failed to push the tissue all the way across the threshold into noticeable arousal changes, the growth factors likely initiated some degree of invisible baseline tissue remodeling. It laid a foundation.
Sounds like priming a wall before you paint it.
Oh, there you go again with the analogies.
Well, it makes sense. The primer itself doesn't look like the finished product, and you might think the wall still looks totally unfinished, but it alters the surface texture so the actual paint can finally adhere.
Exactly. When you go in for the second shot, that new wave of regenerative stimulus is hitting healthier, more vascularized tissue. It compounds on the microscopic groundwork laid by the first treatment.
Okay, that makes sense. Now, looking through the Cellular Medicine Association guidelines, they don't just rely on biological injections for these complex cases. I'm seeing a heavy emphasis on combination therapies. They are pulling in machines like the Mona Lisa Touch or FemiLift lasers.
Yes, combination therapies are very common.
But if the biological signal of the PRP failed to wake up the tissue, why pivot to a laser? Aren't we just throwing random spaghetti at the wall to see what sticks?
It looks like that from the outside, but it's actually a strategy of attacking the dysfunction from entirely different scientific mechanisms. Synergy is incredibly powerful in regenerative medicine.
Okay, how so?
Well, PRP relies on a biological chemical signal. Fractional CO2 lasers, like the Mona Lisa Touch, rely on physical thermal energy.
They create intentional microscopic damage, don't they?
They do. They deliver pinpoint columns of heat into the vaginal mucosa, creating controlled thermal injuries. And this physical microtrauma forces the body's innate healing cascade to aggressively kick in and produce fresh collagen.
Oh, I see.
Sometimes severely aged or atrophied tissue needs that physical thermal shock to wake up rather than just a chemical whisper from growth factors.
So by combining them, you're hitting the tissue with a physical trigger and simultaneously flooding it with the biological resources from the PRP to heal that intentional damage faster. Okay, that makes a lot of sense. And I saw the protocols also heavily integrate pelvic floor physical therapy for non-responders.
Yes, because we have to remember that arousal and sexual function are heavily dependent on musculature. A liquid injection of growth factors, no matter how concentrated, cannot fix poor muscle coordination.
Right.
It cannot release a hypertonic or chronically clenched pelvic floor that is actively causing pain during intercourse.
So if the root cause of the patient's dysfunction is muscular rather than mucosal, the PRP is essentially treating the wrong system. You have to physically retrain the muscles through therapy alongside the biological repair of the tissue.
Absolutely. And we also have to consider the patients who primarily receive the O shot, hoping to cure stress urinary incontinence, rather than sexual dysfunction.
Right, the SUI patients.
If an SUI patient is a total non-responder at 12 weeks, the strategic pivot is much more structural.
Because PRP might thicken the tissue around the urethra to provide some mild support, but it can't repair a major anatomical prolapse or, like, a severe structural failure.
Exactly. The clinical guidelines acknowledge the limits of regenerative medicine here. For severe, non-responsive leakage, the recommendation shifts toward proven surgical interventions, such as mid-urethral slings.
Okay.
These physically lift and support the urethra, boasting incredibly high success rates. It is a necessary recognition that structural problems eventually require structural solutions.
So zooming out from the individual clinic protocols, I want to look at the broader landscape you brought to this deep dive. Because we've been operating under the assumption that the O-shot is a highly effective treatment that simply requires some personalized troubleshooting.
Right.
But the macro-level data, specifically the Ohio State University review of clinical trials we looked at, paints a surprisingly messy picture of this entire field.
Oh, the Ohio State review is a critical reality check. They analyzed the entire clinical trial landscape for PRP applications in female sexual dysfunction. And out of the 18 registered clinical trials attempting to study this exact topic, only 33% were ever actually completed.
Only a third of the trials even made it to the finish line. That is an astonishing failure rate for clinical research. Why are they collapsing?
It points to immense systemic challenges. Trials collapse due to a lack of funding, an inability to recruit enough patients, or honestly, fundamentally flawed, unstandardized protocols.
Right.
When researchers cannot even agree on the basic parameters of how to extract and inject the PRP, completing a rigorous trial becomes nearly impossible.
And what about the data from the trials that did finish? Like, does it support the incredible success rates we see plastered on clinic websites?
This is where the systematic reviews raise massive red flags. The published literature consistently suffers from alarmingly small sample sizes and a very high risk of bias. Crucially, the Ohio State Review noted that none of the studies they analyzed demonstrated statistically significant improvements in sexual satisfaction or arousal across the board in a way that meets the gold standard of evidence-based medicine.
So there is a massive disparity between the peer-reviewed science and the clinical marketing. Because when a clinic markets a treatment as a revolutionary cure, it sets a powerful psychological anchor, doesn't it? And we know the placebo effect is incredibly potent in sexual wellness.
Very potent. And that psychological component makes studying this incredibly difficult. When researchers introduce a sham injection, a true placebo control where a patient thinks they're getting PRP but only gets saline, the dramatic difference in response rates often shrinks.
Wow.
The clinical trials struggle to prove that the biological serum is vastly outperforming the psychological expectation.
So if a patient is staring at the ceiling as a 12-week non-responder, part of the troubleshooting process involves asking a very difficult question. How much of the initial expectation was inflated by marketing that is simply outpacing the rigorous science?
It's a tough question, but it requires navigating the very experimental edge of personalized medicine. PRP is undeniably a powerful biological tool. I mean, the mechanism of utilizing your own growth factors to stimulate angiogenesis is scientifically sound.
Right.
But it is not a magic wand. Its efficacy is wildly dependent on an individual's unique physiological environment and a highly unstandardized application process.
Which really leaves us with a profound reframing of that 12-week mark. If you are sitting there listening to the hum of the world moving on while you feel like your body let you down, your non-response is not a dead end. It is diagnostic data.
Yes, exactly.
It's a clue pointing you toward the real root cause of your symptoms.
It forces a transition from seeking a quick fix to demanding a comprehensive medical investigation.
Your sexual wellness journey is entirely unique to your biology. So whether the solution lies in uncovering a hidden hormonal imbalance, auditing your daily medications, exploring thermal lasers, or simply recognizing the limitations of early-stage regenerative therapies, the key is to keep pushing for answers. Keep questioning the marketing, keep learning about your anatomy, and keep exploring your options with providers who treat you like a complex ecosystem, not just a receptacle for a shot. We'll catch you on the next deep dive.